and we move now on. And I'm happy to report that Dr. Wilson is now supposed to be online with us. Maybe many of you will know Stephanie Wilson for her many research, many lectures on contrast-enhanced ultrasound also. She is She is a practicing radiologist in Calgary, and she is a professor at University of Calgary. And she is now going to talk about the role of ultrasound in complications of IBD. Please, Stephanie, are you with us?
I am. I hope you can hear me.
Welcome. We can hear you. We see your slides and we have your voice clearly. So please welcome and let us know everything about complications and how we can use ultrasound for that.
Okay, I will try to do that. So in this presentation, I will look at the complications of inflammatory bowel disease and our experience in looking at these with ultrasound. So I have worked in a large radiology facility for my entire career, and I've become intrigued with the role of ultrasound for this indication. And I hope that I will share with you my experience, that this is a really excellent tool, that the patients that are at diagnosis, at surveillance, or with acute presentation all can benefit for complication detection with ultrasound, and it is not necessary to go to either CT or MR scan to show these complications. So these are my research grants and equipment support, and the description of DEFINITY in inflammatory bowel disease is off-label. Now, what is our objective when we're performing a diagnostic imaging test in a patient with Crohn's disease? Well, first of all, we want to identify the presence and the extent of disease. And so we're looking again at the patient at their first presentation. We look at them at the time of surveillance. And of course, we look at them when we're looking to detect recurrence following surgery, recognizing that this occurs at a very high rate. And then the next thing that we do routinely, of course, is to determine disease activity. And this is essential at every visit. And we also monitor the response of the patient to therapy. And lastly, what we're going to look at this morning is looking at detecting complications of Crohn's disease. So what are our choices for modalities when we're doing these scans? Well, CT scan, of course, has been a very popular technique historically, and it remains the workhorse for looking at patients in the acute situation, particularly the patient that presents to the emergency department. Now, CT enterography and MR enterography are both very widely used, and of course, there's some greater accessibility for CT, but with the recognized risk of radiation exposure in this population who has a frequent demand for diagnostic imaging. MR enterography is fortunately very available to me in my facility, and although I recommend it routinely, I don't recommend it frequently. And ultrasound, of course, we do multiple patients daily, both routine elective patients, inpatients, and emergency patients as well. And meta-analyses suggest that there's general equivalence between all of these modalities. So let's talk for a moment about CT scan. So CT scan has been the historic workhorse for imaging IBD in America, and recently it has encountered disfavor related to exposure to ionizing radiation. And of course, we're all familiar with the patients from the past who have X-ray bags before we had all of our digital imaging, and patients were exposed to large amounts of ionizing radiation. And so although this has declined tremendously for routine surveillance of patients and even for diagnosis, it still remains as the most popular test for imaging of the patient at the time of acute exacerbation, and also when these patients have an emergency presentation. And so the performance is very good, excellent identification of complications. But in our own institution, we've attempted to suggest that ultrasound looking at emergency patients and acute presentation patients does equally as well, and that there's very rarely indication for performing CT scan in the middle of the night, for example, on a patient with known Crohn's disease. So when we look at ultrasound, we have, of course, this has been very nicely described by the two prior speakers, we have standard grayscale evaluation that allows us to see without any additional contrast agent requirement all of the layers of the bowel wall. So ultrasound affords superb spatial and temporal resolution. And of course, the real-time multiplanar acquisition of imaging of the bowel is really requisite, and it just allows us a really exquisite visualization of the bowel wall. And so color Doppler has also been touched on. It is a sensitive depiction of blood flow, and color Doppler imaging is a qualitative assessment of the enhancement of the bowel, and this is an estimate, of course, of disease activity. And so not to show these in any detail, but here we're looking at a patient where we're looking at an axial and a long axis view of the bowel. And so we would record these images regardless of the reason why we're doing this scan. So we're looking here to assess the bowel wall thickness. We're looking at the stratification of the bowel wall. We're looking at the lumen, and we're also looking at the appearance of that echogenic perienteric fat. And we recognize that all of these observations increase as patients have increasing inflammatory activity. Now, if we add color Doppler, of course, to this image, you can see the beautiful enhancement of the vasculature within the bowel wall and also within the mesentery. And so color Doppler is very good, but it's inferior to contrast enhanced ultrasound, which shows us blood flow at the perfusion level. Now, what about the complications of Crohn's disease? Well, basically, I divide them in my mind into two groups. And so the first, of course, is the fibrostenotic or strictured bowel, which is associated with mechanical bowel obstruction. And the second are the perforating complications, which lead to fistulae, inflammatory masses, and are associated additionally with perianal inflammatory disease. And lastly, we'll touch briefly on neoplasia. And so when we're looking at the fibrostenotic complications of patients with Crohn's disease, what are the things that we look at? Well, you can see on the images on the top line that we're looking at bowel here that has excess fluid content and increased caliber for what we would expect on a fasting patient. And so the patients that come to us electively are fasting, but as has already been mentioned, patients who come in an emergent basis or whenever they come, if they've eaten, we scan them as well. So we look at the bowel and we become suspicious, or we become focused on the fact that there might be something going on distal to those dilated loops that we see on the top line. Now, in addition to looking at them on a grayscale still image, which we show, we also look at their real-time characteristics. And so you can see on the bottom image, or the bottom panel, that we're looking at an AVI acquisition of the bowel that shows to and fro peristalsis. And so normally the peristalsis in the bowel is only antegrade. And so when we see this increased caliber and we see the content going both forwards and backwards, that would increase our suspicion of a distal obstructing lesion even more. And so on the panels shown on this patient, we can see on the left-hand side that we're looking at two panels that show that there is a strictured segment here with dilated prestenotic bowel shown here. And so this is a typical appearance for the dilated prestenotic bowel, where oftentimes there is air at the front of that portion of the bowel, making a distal shadow as we see here. And then we would study this portion of the bowel, looking at the thickness of the bowel wall, looking at the lumen, and then assessing to see if that lumen opens or whether it stays closed. We would then, of course, look at this with color Doppler. We would today look at it with elastography as well. And of course, on the panel on the right-hand side, we're doing a contrast-enhanced ultrasound exam of that strictured component, showing that there's transmural enhancement, and we would quantify those parameters as well. But here, when the contrast comes in, you can see quite profuse enhancement of that bowel in that strictured segment of the bowel. So what about correlation of what we see on ultrasound with what we see on CT scan? Well, here's a patient who presents, 64-year-old female with no diagnosis of Crohn's disease, and she presents to the emergency department in the middle of the night, of course, with a high-grade mechanical bowel obstruction. So when we're looking at the CT scan, similar to what I've already described in the ultrasound scan, we can see immediately that there is increased caliber and increased fluid content in those loops of the proximal small bowel. And so we, of course, are looking at these images on both coronal, axial, and sagittal plane, and we're looking for a point of caliber change. And so at this point, we can see that there's a thickened segment of the bowel with hyper-enhancing mucosa. And we can see also this lovely comb sign reflecting vascularization of the mesentery in that portion of the bowel. Now, when we look on the coronal and on the sagittal image, we can see this segment of bowel better. And so in this patient with no prior diagnosis of inflammatory bowel disease, we can see this abnormal segment. So let's look at this same patient who was scanned within hours on both ultrasound and CT scan. So again, as soon as we place our probe on this patient's abdomen, we can see these dilated, fluid distended loops of bowel. So this would never be a normal appearance on anybody, regardless of whether they're fasting or not. And so, of course, we're suspicious immediately that there's potentially a distal obstructing lesion as the most likely explanation. So again, we would examine the entire abdomen, and as was nicely pointed out in the first presentation, we have to have a method whereby we can see virtually all of the bowel by doing a systematic evaluation of all of the quadrants and looking for, of course, what we see right here. We see dilated bowel, dilated bowel, dilated bowel, but in the center we can see a thickened portion, nice stratification, luminal apposition, and we can see that this loop of bowel is obviously different. So now we want to try to see the place where these dilated loops of bowel actually connect to the bowel that has this appearance. And so when we're looking in real time, we're surveying around to find that point of alteration. And so although the images altered to some extent by the peristalsis that's obviously in that region, you can see as we go through this little clip, which is now looping and starting over again, that we can show that this is actually a beaked appearance, and this is the point of caliber change, and that this is obviously a thickened, quite distorted portion of the bowel. So we record these sweeps, and here we're looking in the axial plane where we're coming from the thickened segment, and we're moving more proximally onto the dilated segment of the bowel where the wall becomes thin, and there's a transition between the thickened distal bowel and the thin wall that surrounds this dilated and obstructed segment of the bowel. Now, so we come to this point of obstruction, and then we try to evaluate this in greater detail. And so here, as was pointed out very nicely in the first presentation, we might alter our transducer. We might go from a lower to a higher frequency transducer, and we're trying, of course, to show the change of the bowel at that point. So here you can see that the bowel lumen is dilated from the arrow going to the right side, and the luminal surfaces are in apposition as we go to the left. Now, as we go up onto the more proximal dilated bowel, the arrow marks the point of transition, quite abrupt transition, with thickened bowel wall to the left of the arrow and thin bowel wall to the right as we look at that dilated segment. And just another view of this in the long axis, where we can see that this is all thickened and abnormal bowel, and then this transitions in to a normal bowel wall thickness. And when we look in axial, we can see that the two images on the left, of course, represent this bowel where it's transitioning from thickened bowel down to more normal bowel. The thickening's eccentric here, and that then when we come right onto the strictured portion, you can see that there's a portion with wall layer loss. The luminal surfaces are in apposition. There's big surrounding inflammatory fat. And so this would suggest to us that the obstructing cause would be an inflammatory lesion. We, of course, add color Doppler, as we can see here with the grayscale image in axial on the left and the color Doppler on the right-hand side, and we would also do bowel elastography. So now, we saw a very nicely presentation about looking at bowel elastography using strain, and we in our institution use point shear wave elastography. And so our hypothesis, looking at strictures in patients with Crohn's disease, our hypothesis at the start of our study was that the elastography correlates directly with increased chronicity and inversely with inflammatory change, as shown on CEUS. And so this has proven to be important for differentiation of inflammatory from chronic strictures, in that we have high values with chronic fibrotic process and low values with acute inflammatory disease. Now, what we've also found in our own patient cohort is that muscle hypertrophy, in fact, is most important, and that the amount of fibrosis in virtually all of the patients where we've had histologic proof is present. Fibrosis is present, but often inconsequential. And so we use CEUS and point shear wave elastography together to look at blood flow at the microvascular level and to measure wall stiffness. And we believe that this is valuable not only looking at strictures, but for monitoring therapy and assessing the chronicity of these strictures, and of course, as was nicely pointed out by Dr. McConey, for predicting the requirement for surgical resection. And so we actually looked at 150 patients in our initial study, only 15 of whom had surgical resection and correlation of their pathology with shear wave elastography and CEUS. Now, I'll just show you one of the patients that we had in this study. This was a middle-aged male with long-standing Crohn's disease and presented with obstructive symptoms of bloating. And I think that ultrasound with CEUS and elastography has a big advantage over CT and MR scan for one very important reason, and that is our ability always to interact with the patients. And so patients who might, with a fasting abdomen, not show as much, these patients, as soon as we see this dysfunctional type of peristalsis, as we're looking at here, our questioning will often very, very quickly allow us to realize that bloating and obstructive symptoms are the things that are most troublesome to these patients. And so on the left panel, we can see a thickened segment of the bowel with loss of wall stratification. There's hyperemia and luminal apposition. Now, so how do we do the point shear wave elastography? Well, these upper panels, the axial and sagittal pictures, show a beautiful stricture. So we can see the bowel wall right at the stricture with total loss of the wall layers, the lumen fixed and narrowed in the middle. And then we can see on the long axis view, here's our pre-stenotic dilated segment of the bowel coming into this very abnormal configured, now eccentric lumen with this big thick wall with no wall layers. So we found that although we have considerable variability, if we see an image like this, we like to try to place our point shear wave region of interest on the axial view, in that it allows us to best avoid the lumen and to avoid the perienteric fat. And so although we have not published this yet, certainly in our own data, a point shear wave velocity of 2.8 meters per second is very high, and we would predict that this would be a very chronically abnormal bowel. In addition, on this patient, we got almost no blood flow on contrast enhanced ultrasound, and you can see a very low peak velocity of 16 decibels with a similar very low area under the curve. So we predicted that this patient would require surgery, and this showed a stricture, confirmed a stricture with severe chronic change. And so here's the pathology on this patient, and so we can see that there's very low inflammation on this stiff bowel, And this, of course, this pink tissue is muscularization with increase of the muscle component from both the muscularis mucosa and also the muscularis propria. And so our pathology, Dr. Sean Gouy, he's actually published this, the fibrostenosing phenotype of Crohn's disease, and he's emphasized that the most important component of this, which is very logical when you consider the elastography results, is muscle hypertrophy. And another very important thought that comes from these results is that although we use wall thickness as the most reliable grayscale indicator of activity of disease, there's a cohort of patients who have very thick bowel, such as I've just shown you. And this thick bowel measures, in fact, over 1 centimeter in thickness, and yet it does not reflect activity. It reflects chronic hypertrophy of the muscle, causing this marked increase in the caliber of the bowel. And so if we look at a normal bowel on the left and the strictured bowel with the muscle hypertrophy, you can see the tremendous difference in the appearance of this loose connective tissue as compared to this muscularization, which has that striking pink appearance. Now let's look at another patient who presents with a stricture. Here's the pre-stenotic dilatation on the long axis view. And in this case, you can see that although the luminal surfaces are in apposition, that the wall layers are beautifully maintained. And when we look at this patient with our shear wave elastography, we have a very low value of only 0.6 meters per second. So everything less than about 1 we found to be very suggesting soft bowel. This patient was treated medically, and when she returned about 6 months later, virtually her bowel had returned to normal. Her symptoms were gone, and she had no residual evidence of incomplete mechanical bowel obstruction. So let's look at another patient. This is a female patient we saw recently. She presents with loose stools and weight loss, and she has a newly diagnosed Crohn's disease at 72 years of age. She's on no medication, and her initial colonoscopy encountered a failure to intubate her ileocecal valve. So she comes to us for us to assess the status of her terminal ileum. So when we're looking, we can see immediately, we're just looking in her right lower quadrant, we can see that there's a loop of abnormal bowel there with quite marked thickening of the wall and a fixed acute angulation as the bowel goes deep into the pelvis. Now, when we look at this, we're concentrating here doing our focused assessment. We can see this loop of bowel quite well, and we can see this fixed acute angle. We can see a profuse vascularity on color Doppler imaging, and perhaps we're a little suspicious that there may be something going on in this angle. And so what do we do in my department? Well, why might we do an endovaginal scan? Well, so we have a very low threshold for providing or for performing endovaginal sonography, in that over the many years that I've done imaging in patients with inflammatory bowel disease, there are so many patients where we've seen striking pathology on endovaginal scan that we don't see on the suprapubic imaging. And so let's look at this lady. So when we look at that loop of bowel, we can see, first of all, that it's fixed and rigidly with a fixed narrowed lumen. And then when we come to the end of this little portion of the clip, we can see that the bowel is dilating. So this is suggesting to us a stricture. And note also in this loop of bowel, when the clip starts over, that there's a focus of air on the bowel right there that suggests the air is very close to the surface of that loop of bowel. And so when we look again further in the long axis view at that loop, there's that portion with the air right at the surface of the bowel, right to the serosal margin. And that allows us to take a picture like this, which would suggest that this patient, of course, she presents clinically unwell, and that this would be a imminent perforation situation. And this very deep ulceration was confirmed. This patient went to the OR, and this bowel is resected. And this brings us to talk about the penetrating complications of Crohn's disease. So this is a young man we've scanned many times with disease in his descending colon. And so you can see his axial and long axis views on the top panel. And then on the panel on the right, we can see that there is inflammatory.
Stephanie, sorry to interrupt you. You are over your time now. Please come to a conclusion.
I will. I apologize for going over my time. I hope that I've shared with you, even in the stuff I have shown you, that ultrasound, I believe, does show the stenotic and penetrating complications of Crohn's with great accuracy. And so for the patient that comes at diagnosis, for the patient undergoing surveillance, and for the patient with acute presentation, I think ultrasound plays an excellent role. Thank you.
Thank you very much, Stephanie. This was a very nice lecture with extensive cases, and we have learned very much. And we have some questions from you, from the audience out there in the world. We have one from India. He asked, we see a lot of tuberculosis in the GI tract. Do you think that gastrointestinal ultrasound has any role in differentiating Crohn's disease from GI tuberculosis?
So that's a great question. And actually, I should ask the person from India that question, because of course they see so many more patients than we do. So I will tell you that I think we do not differentiate Crohn's disease and tuberculosis well. So in my experience, we have had several patients, only a handful of patients, but nonetheless still several patients who have had bowel resected for what looks like intractable chronic inflammatory change with increased stiffness on elastography, the whole match. And then the pathology shows tuberculosis. So I believe it is very difficult to accurately differentiate. And I think that our suspicion, of course, rises when we look at patients who come from geographic areas where it's more prevalent, but this is not universally successful.
Yes. And another question regarding elastography. Do you have now in your material any specific value to categorically differentiate between fibrotic and inflammatory strictures?
We are trending towards, we do. We have velocities below which we think there's no fibrosis in the bowel wall. So that would be around 1 meter per second. Once the bowel is stiffer, so that we have values over 2, we're starting to think these patients have chronic change. And we're looking, as obviously your former 2 speakers, we're looking also at the prediction with stiffness for response to therapy, in that we believe that patients with very stiff bowel at diagnosis won't respond well to therapy. But
yes.
But there's a gray zone. Definitely, where I think inflammation does contribute to the stiffness, because it will improve if the patient responds positively to therapy.
And along the same line regarding elastography, there are patients of different habitus, different body sizes and types. Would that in any way affect the result of shear-wave elastography? Are you taking that into consideration somehow?
That is also a very good question. So we have found in our liver studies that BMI in general increases the variance of results when you're using point shear wave elastography. But nonetheless, this is one of our reasons why we trend towards shear wave, is that I believe it's more versatile in the large patient. And no, I think if you get all abnormal results, I think that you can rely on the fact that your results are abnormal. Although you have to recognize that the fatter the person is, the more variance there will be in the result.
Okay, thank you. And then a final question regarding also elastography here. What about patients with acute on top of chronic disease? Can you use shear wave elastography to differentiate?
So I believe that acute on chronic disease is a challenge for certain. However, that the tendency for patients with long-standing inflammatory change to develop fat in the submucosal layer of the bowel is very suggestive of chronicity on ultrasound, as it is, of course, on CT and MR scan as well. And so if we have that appearance, and then we always do contrast enhanced ultrasound, and so many patients that I would have called 20 years ago just chronic inactive disease, I now realize they're acute on chronic. And so that's determined in my mind by a combination of elastography, grayscale showing that in thin or that echogenic submucosal layer, and CEUS.
Okay, I think we have to move on to the next lecture. Thank you very much, Professor Wilson, for your excellent lecture, and see you later.